now today we are wrapping up with our next session called Translating Talk into Action with Dr. Susan Perez and Ms. Kelly Davis, who will engage in a dynamic discussion about the different things that we learned today and how we can turn it into action.
Hi, I'm Susan Perez, and I'm here with my dear friend and colleague, Kelly Davis. So I think I'll start by introducing Kelly. What is most incredible about her and her work is the ability to take an anti-racist, health equity, and trauma and resilience informed care approach to medicine, helping doctors recognize those as aspects of the patient's context of their own lived experiences, and not separating those inequities, racism, and trauma from the patient care. I'm Susan Perez. I'm a health services researcher by training, and I frame my research as a health services researcher who centers the experiences of patients in quality education and policy making.
Thank you so much for having me. I'm so excited to be here today. My name is Kelly Davis. I am the co-founder and chief equity officer of Kinshift, which is a consulting firm that works at the intersection of trauma and resilience informed care and anti-racism for healthcare and public health system transformation. We came to this work after over 10 years at the New York City Department of Health and Mental Hygiene, where I was very lucky to helm for the first time ever a project working in maternity hospitals to address racism and bias in the hopes of saving the lives of Black birthing people who in New York City at the time were 12 times more likely to die of a pregnancy-related cause than their white counterparts.
So today's conversations, as Kelly and I have been following along and all the speakers and taking notes, and what I observe foundational to this conversation is that notion of trust. And that means all parties, the provider, the patient, and even the patient's care team, bringing their whole selves to this relationship. And I'm starting with this concept because this is something that I've had the privilege of working under Kelly's leadership. And in doing this work, even at the level of researchers and not even providing direct patient care, we bring our whole selves to that engagement or to how we interact with each other. And I think that's so key in this equity work because it's about building trust. And it's also what I've heard too, and I've kind of like drawing some themes. It's that shared language and communication. So some examples is if a doctor, even when talking to Kelly, we even talk about shared experiences with our childhood. So when I tell her about a problem or an issue, I know what the shared language that we have. And even in talking to my doctor, there's that shared language of trust with the doctor. Like, does that doctor understand the experience of my birth, the birthing experience from discomfort or pain? Or can I trust the doctor to understand cultural practices? I admit, like, I lied to my doctor because I looked at this doctor and they did not share the same skin color or eye shape as me. And so I didn't disclose that I was co-sleeping or that some of the medicinal foods that my mom brought to me after birth. And it was very stigmatizing and almost traumatizing because the risk of disclosing those things is child protective services, whereas you go to entire countries and all parents are co-sleeping and eating these medicinal medicines. So I'm so interested to know from you, Kelly, is how do we continue to bring that trust and expect providers and patients to bring their whole selves, but at the same time, that vulnerability when we've been so harmed by otherness and a lack of understanding?
Well, I think, one of the clear and key themes that we've all heard today was that we need to stop asking folks to trust us more and think as systems, how do we become more trustworthy? I will say that we tend to think about person-to-person interaction. So how can I, as a physician or a clinician, work on becoming more trustworthy with this individual patient? However, I think what we don't tend to recognize is that we are dealing with historical mistrust of systems, that even if I am a good person, even if I am trying to actively work on my biases, you are an emblem of that system. I think a lot of times, really, you can think this year or last year, the last 2 years with the COVID-19 pandemic, and how even different states, different cities have interpreted guidance around COVID-19 transmission and risk factors differently for the same virus, depending upon what state that you are in, and how that has actually eroded kind of public trustworthiness inside of medical systems. If we have a commissioner of health in Florida that's saying there's no need to mask and saying that vaccines are not proven to be effective, how does that either counter with the changing guidance that we've seen over the past 2 years from the federal government and all of the things that are impacting what is happening within our 15 to 20, 30-minute clinic visits, right? And so we're in stackable systems, and it's not just my relationship with a patient, it's the patient's relationship with the clinical hospital system as a whole, the patient's experience in their community. All of those things really impact whether or not someone is even able to receive information that we're impacting or that we're trying to influence their health and outcome. So I think it really starts not only just thinking about ourselves, but entire systems, and how trustworthy is the system that we are in. And for a lot of folks that have marginalized identities, whether they be along the lines of gender, immigration status, sexual orientation, the truth is that healthcare infrastructure, healthcare systems, public health has actually not been a trustworthy system. And so we start by acknowledging that, figuring out how to advocate to our systems, using our privilege at different levels of leadership, and really having those conversations that we've talked a lot about active listening today, but the truth is active listening is still under the guise of this agenda where the physician is setting the agenda, right? So I say something to you and then I actively listen to what your response is. But what happens when we turn that on its head and let the patient or the most marginalized person in our system set the tone and the agenda for the things that we would like to discuss?
Thank you. That's incredible. Absolutely. We heard that a lot today. And I was also struck me to your point is what I'm hearing is patients are coming into these systems already traumatized, already having a trauma response in their body. And Dr. Rita Sharon kind of even talked about how our body is how we experience and interact with the world. But, you know, it also is protecting us from harm. It's protecting us in harm. At least, you know, when I experience a traumatic, I just freeze, tune out, and like just stop engaging. You know, and this whole idea of like health literacy and engaging, or patients even seem disengaged because they're even just walking through the doors of the hospital invokes that trauma response.
So I think that's when we think about health literacy, in many ways, I hate the term. In many ways, I hate the word literacy, because literacy is literally just, can you read? And that's very different than health comprehension and health understanding. And what we know around neuroscience, around trauma-informed care, is that when you are experiencing traumas, whether they be acute or chronic, like exposures to racism and other spheres of oppression, the truth is that our thinking brain goes offline. And so how can we receive information, even if we are literate, right? Even if we can tell the words that are on the paper, if we are currently under stress, long-term, that is debilitating and really impacts our ability to understand kind of complex instructions around medicines, around a whole host of things, around health behaviors. And so that's why I really think that really any kind of discussion around health literacy without really understanding the mechanics of trauma-informed care will never meet its full potential, because health literacy at its best requires everyone to have the ability to not only read or hear, but to understand. And we also know that that really marginalizes not only communities of color, but other kinds of folks that are disabled, that do not have the ability to actually even experience a lot of information in the way that we tend to impart it in our systems, which is, via forms, via pamphlets, via verbal conversations. And I think about oftentimes the information that's being input to patients when we are even meeting the gold standards of health literacy. So much of communication is nonverbal. And in our work at Kinship, when we are providing support to clinicians and healthcare systems, we hear all the time, oh, I have to call the language line. Oh, this patient, who can talk to this patient? And we know that that imparts from the outset, even if the patient does not have an understanding, a kind of reticence, reluctance to actually serve, which we know impacts even the most privileged of patients, right? Susan, you and I, we have degrees, we hold positions of leadership, and you started off by saying you lied to a clinical provider because you are afraid of other systems of oppression converging to harm both you and your children, right? So think about if that's what we are doing as women of color with advanced degrees, what are people who are undocumented, medically transitioning, living in unstable housing? What does health literacy or health understanding or health comprehension look like for them?
That's just so incredible to me, Kelly. It's interesting as healthcare providers, when you're saying they're calling those lines, it's that over reliance on that verbal communication. And what I'm hearing is there's so much more to communication and just sitting there in the presence and observing as a provider doing that. And I would love to dive deeper with you in that notion of health comprehension, because I think when it comes to health comprehension, there you create a shared space of knowledge, and it's that comprehension of that individual's health. I think literacy is, like you were saying, it's so definitive. It is an alphabet that you can read. It is numbers that you can understand, versus comprehension, I think, just creates this shared space of knowledge where we come together as provider and patient to understand. And whether it doesn't rely on that verbal language or that alphabet, but rather that communication you're also speaking about.
Well, I think that that's key. I started off my career in public health and healthy eating and active living. So I heard earlier from the primary care physician talking about hypertension and chronic disease. And what I learned there, working in a community in New York City, which had the highest proportion of students that dropped out of middle school, not high school, but middle school, is that there was so much around literacy, period, let alone health literacy. And a lot of the clinical advice calls for things like addition, right? Not only reading letters, but also numbers, which is a different type of literacy when we think about sodium in grams. And so having a clear understanding around health literacy challenges, even for folks where English was their primary language primarily, let me realize about how healthcare guidance needs to shift. For example, we wound up stopping asking folks to look at milligrams, because even the concept of what a unit of measurement like a milligram is, I can't even eyeball a milligram, right? And yet we're asking folks to measure those when managing a severe chronic illness. And so we had to stop thinking around what we think of when it comes to nutrition and healthcare guidance, and how do people receive information. So it started looking like, okay, Goya beans, the low sodium can has the light blue label. When you're buying beans, look for the light blue label. Or look for no salt added, right? So no, and salt or salt shakers. And so it really, that is when you move from literacy into comprehension, those are the kind of conversations you begin to have, because you move from your context as a clinical system, or your context around quote unquote evidence-based clinical guidance, into the system of what is the context of this person's life, what is available, what is affordable, and how do I situate what I know the clinical guidance is to their life context and their current level of comprehension, so for the best possible outcome.
And what I did not hear today is a lot of the work I do is shifting to the more pragmatic. As we begin to reframe health literacy, we're going to have to make a huge ask of our healthcare providers. And what I didn't really hear a lot today, because I'm anticipating pushback, is that idea of provider burnout. We're already asking so much of them, and now we're asking them to reframe their interactions or even their way of thinking. I want to bring in that aspect of the provider burnout into this space. And then also perhaps if we can have it in the context of when we do these litter things, it is often our providers of color who are often asked more, or providers who come from these lived experience, who share some of the experience with their patients from the more diverse backgrounds as well, who tend to experience that burnout, because they receive the harm in two ways. They receive the harm of burnout and treating all these patients, and then harm in witnessing their colleagues harm patients through lack of understanding.
And also experiencing harm themselves, right? So trauma is not just for patients. We have providers that are often marginalized within healthcare structures, right? There's often a snow capping of institutions. Even you and I work primarily in obstetrics and gynecology, or maternal, infant, and reproductive health. And yet the chairs of obstetrics in most healthcare systems that I've worked in have been white cisgender men that do not live in the communities that they're serving, particularly if those communities are in public hospitals or FQHCs or lookalikes, versus the MAs and nurses, which tend to be women of color. And so there's often, they are experiencing the same systems of oppression within the hospital settings, which influences how they are paid, how they're promoted, who gets to publish and who doesn't, right? Who, even down to scheduling, all of those things impact clinical care, right? And so in our work, we work a lot with Trauma Transform in the East Bay area for children in California. And there's a statement that says trauma that's not transformed is transmitted. And so we often see that folks are transmitting trauma that they experience inside of their own clinical systems due to marginalization. We tend to pass it on to the people who have less power, right? So doctors can pass it on to nurses, nurses can pass it on to MAs, and we all pass it on to patients, right? Which impacts, again, their ability to absorb information, right? When you don't feel respected, when your fight, flight, or freeze impulses are activated, we know what happens. And that's really just on a good day without COVID. And clinical systems, because of the noise, because of the invasive touch, because of the overhead lighting, often resemble or trigger folks that we already know are coming into our clinical systems traumatized. And we further do that traumatization in every way, through the ways that we communicate, through our forms. If folks are not thinking about forms, please do. Health literacy is not just one-on-one verbal communication. It's also when we ask someone, someone who might be a single birth parent, who is the father, and we don't think about parents or genders or allowing folks to self-describe themselves. All of those things impact folks' ability to even accept clinical guidance, right? When we know from the outset they're coming in and they're not even signs telling them where is the phlebotomist in their own language.
Kelly, I'm just so grateful to know you. To all of you who are listening, is every time I talk with Kelly, she leaves me thinking for weeks. These words, these statements, and I hold on to them and I walk with them, just indefinitely. So, just thank you so much for this conversation, Kelly, and thank you for all of your work. I am just so grateful to be in this space with you.